Okay, well, let's get started. And so, again, I'm Phyllis Slade Martin, co-chair uh, of our wonderful health equity work group. Please pardon me. I'm not sure why my camera is not working, so I'll have to engage off camera today, but we will press forward. And so I just want to welcome everyone for the month of our monthly meeting in May. We have lots in store for you and look forward to your participation. Zerxazer, would you like to do the introductory activity?
Sure. Hi, good afternoon, everyone. Is there an echo? Can everyone hear me okay?
I can hear you
Good.
okay.
I can hear you.
Wonderful. Great. Thank you. So yes, thank you again for joining this afternoon. Again, my name is Zerxazer Coyote, and I was introduced in the last meeting as the new co-chair for the Health Equity Group. So I'm really glad to join and to participate in a more leadership role with this group and coalition and working with all of you. So our activity for today and introducing ourselves is just to indicate what your favorite summer activity is in Maryland. If you have a specific area in Prince George's County, that would be great too, so that we can know. I'm currently outside at a Starbucks, but if anyone had a favorite summer activity, whether it's outdoors or indoors, that'll be our icebreaker for today.
Well, I'm happy to start to say that one of my favorite activities are the Sunday afternoon concerts in the parks. So I love the variety of concerts and all the locations and the settings. Yay to Maryland Park and Planning.
Anya, looks like your hand is raised.
I really enjoy summertime gardening, taking care of the garden. That's my favorite.
Swimming in the summer.
What was that in the summer?
Swimming.
Swimming. Okay. I would have to agree with Phyllis. I love outdoor concerts and just listening to music in the park. So that's definitely a favorite activity. I see Kim, your hand is raised.
Sure. I do love a good Maryland snowball, but I grew up going to Six Flags, which was once I think Wonder World, and it became so many different names, but now my daughter also likes Six Flags, so we really appreciate having that close by.
Great. Anyone else want to share your favorite summer activity in Maryland?
Well, these are all great ideas. Thank you so much, everyone, for sharing. And we'll move on to the next agenda item, which I believe Kim will introduce.
Absolutely. So I know we mentioned that we would like to remind everyone of the vision for the group. So I'm happy to go over that if you'd like, or is there say so if you would like to.
Oh, sure. Yep. So I'll just read the screen right now and then elaborate a little bit. So Prince George's County is a place where everyone has equitable access to achieve their full health and wellness potential, regardless of race, color, religion, country of origin, immigration status, class, age, disability, sexual orientation, gender, gender identity, or health literacy skills. So that is our vision for the coalition.
and more specifically for the health equity work group. You'll see that it's very much, as Zerk was reading, is very much in line with when we look at definitions of health equity. Thank you, Zerk. And so I'll do just a quick overview of our previous meeting. We were very fortunate to have Jacob Riley to join us at our last meeting and share the community health assessment summary. And he provided really helpful overviews of some of the things that continue to persist and some of the challenges that exist in the that we found through the community health assessment. And just a couple things that stood out, and as we begin to move toward looking at our future goals, is that one, the significance of significant health disparities persist. The Prince George's County population, we're challenged by the fact that the Prince George's County population is aging. Access to health care remains an issue. And there still is a feeling that there's a lack of quality health care providers. And certainly, as we all know, and as persists in the county, the social determinants of health drive and certainly impact the disparities that we see. And the other thing that stood out in his report is that chronic conditions continue and are significant in the county and result, of course, in poor health outcomes throughout the county. And so the thing that really stood out was, again, when we look at the significant disparities that we see in health. The other thing is we had a very robust discussion on the state of health, and we referred to historically marginalized communities. And as we looked at acknowledging the Minority Health Month. And so, as we recognize that we're really not talking about minorities, we're talking about marginalized communities. So we had a really great discussion, and I encourage you to watch the video from the meeting on that part of the discussion. We also had the Terrapin Think Tank, a group of students reported and gave us just their brief updates on their work on the Health Equity Champions curriculum. They are pushing through as they are ending the semester and moving on to other things. They are and have expressed full commitment in finalizing and making recommendations related to the curriculum. And I do want to say, if we have any of the students here today, at the end of the toward the end of the meeting, if you have anything that you want to report on, please feel free in those comment sections. Okay, thank you.
Thank you. So for our next presenter, we recognize that racial disparities do exist in maternal health. Specifically, nationwide, Black women are 3 times more likely to die from a pregnancy-related cause than white women. And Black Maternal Health Week just passed. It was April 11th through the 17th. So we really wanted to take the time to recognize the differences in birth outcomes and teen birth rate by race and ethnicity within Prince George's County specifically. And after that, we'll share some of the programs available within the health department to support residents during pregnancy and after childbirth. So I would like to welcome Ms. Deborah Collier, our epidemiologist with the Prince George's County Health Department Office of Planning and Assessment, to present on current maternal health data.
Can you all hear me okay?
Yes, I can hear you.
Okay, good. Because I was trying to turn on my camera and my microphone before, and it wasn't really working. I was trying to say my activity for the summer was that's why I put it in the chat. It wasn't. I was having some technical difficulties, but mine was concerts in the park as well as farmers markets. So that was a really good icebreaker. But I guess to get back to the data, I'll be just like Kim mentioned, just a few minutes to discuss the Prince George's County Community Health Assessment regarding maternal and infant health and health equity. So you can go to the next slide. The first slide is just looking at infant mortality by race and ethnicity. The overall infant mortality decreased from 11% from 2019 to 2020 to a low of 5.5 per 1,000 live births. However, among Black non-Hispanics, the infant mortality increased by 10% to 8 per 1,000 live births from 2019 to 2020. And another interesting point to kind of note here is Black non-Hispanic infant mortality is nearly twice that of Hispanics in 2020. I'm not, I guess it probably um, makes the point to just understand better what are some of the issues there with when it comes to infant mortality, and just to better understand what some of the issues are when it comes to those disparities. Next slide. The next slide is percentage of low birth weight by race and ethnicity. Infants born with low birth weight has consistently been the highest among Black non-Hispanic mothers from 2016 to 2020. And you can go to the next slide. Um, this is I'm looking at teen birth rates for women aged 15 to 19 by race and ethnicity. The teen birth rate decreased from 19.3 in 2017 to 16.5 per 1,000 women ages 15 to 19 in 2020. But at the same time, it more than doubled in Hispanic teen births. For Hispanic teen births. On the next slide. And this is just a summary of some of the disparities and trends reflected in the community health assessment, as I mentioned in the previous slides. And it's just, a better way for us to kind of target some of these areas. And I know Kim had mentioned that it'd be the next presenter will be providing resources for mothers um, for trying to tackle some of these disparities. One of the things that I don't have a slide for, but I also wanted to mention that Kim mentioned briefly was the pregnancy-related mortality. It's not reflected in the chart, but I did want to kind of talk about some of the data that we had from 2008 through 2000. And again, I don't have a slide for this, but I wanted to mention it. From 2008 to 2017 in Prince George's County, there were 35 pregnancy-related deaths, with the average maternal age being 33 years old. And although Black Hispanic women represented at that time only 59% of the births in the county, they accounted for 82% of the pregnancy-related deaths during the same time period. Also in 2017, the pregnancy-related mortality in Prince George's County was 26.1 deaths per 100,000 live births, which was a decrease from a high of 33.1 from 2010 to 2014. But the pregnancy-related mortality rate for Black non-Hispanic mothers was nearly 1/3 higher compared to all other mothers. So a lot of data that is a little bit outdated, but I think it's reflective of what we're also seeing now. And if anyone's interested, we were planning to update some of these data metrics um, um, with some more updated data moving forward. So if anyone's interested in it, I can give it to Kim to provide to you all. And that's all I had. Did anyone have any questions?
Did you mention that was that 82% in that earlier statistic that you gave us with mortality?
Yes. Like I mentioned before, even though they accounted for about 59% or 60% of the births in the county in 2008, from 2008 to 2017, they did account for 82% of the pregnancy-related deaths during the same time.
Wow.
Yeah, it's really daunting.
We have a couple hands up. I think
Okay.
Anya and then Sharon.
Great, thank you so much for this overview. I had a question whether, so let's say if we're looking at the infant mortality for Black non-Hispanic women, if there is any additional data that actually demonstrates the, I guess, like interception of various, like of other factors, because I'm assuming that there is a great diversity in outcomes, right, for different, for like for our communities. So are there additional disparities? Maybe there are additional correlations with socioeconomical class, right? Socioeconomical indicators. Maybe there are additional patterns that you can see with regards to geographical location. So I'm just curious to see if there is, I guess, like a second layer digging deeper into understanding the disparities instead of just looking at, like outcomes for Black versus white versus Hispanic when we live in such a diverse county.
And oh, I'm so sorry. Just to add to Anya's question, because I think mine would also correlate with that, is that so also, for example, do we have information on say uh, uh, US born mothers versus those who are not US born? Yeah, so that's to add on to Anya's question.
Okay, just for clarity, so the data that I provided with the slides, that is community health assessment survey data. The data that I presented after that regarding the pregnancy-related deaths, that is from CDC's Wonder databases and um, um, their online data, their online.
Can I? Hi, good afternoon.
Surveillance. So the data. So the data sources are vastly different. And so from the CDC data source, obviously there's other ways to kind of look at that data and further break it down. The community health assessment data is a little bit harder. That would probably be more qualitative data analysis, and we have not done that as yet with the community health assessment data, but it is something that we're exploring.
So I could jump in just a little bit on that. My name is Dr. Kristen Newman, and I'm with the Prince George's County Health Department. And so I'm going to present on the next component, but I also am the fetal and infant mortality review and child death review coordinator in the county. So that, to answer the questions, some of it can be determined. So you can look at some of the socioeconomic factors, but we do find that women who have doctorate degrees still have poor outcomes. Women who have less than a high school education have poor outcomes. Women who have six figures have poor. So there's a lot of factors, and some of it is, we can definitely contribute some of it to structural racism even. So there's so many different factors that factor in. The secondary question that you asked about foreign born versus, United States born, it's the data can be found, but it's not going to be 100% accurate, I would say, because sometimes that data isn't reported. So one thing to know, all of the data we get relative to this is self-reported data for the most part on birth certificates, right? So when the birth certificates are submitted to the state, then that information is correlated and then reports are written. There's actually some reports where you can see some information, but not that's specific to births, but it's not specific to cause of death. So for example, we do a lot of that in fetal and infant mortality review, and maybe I can come back and give some, maybe some highlights at another time for that. But when data is self-reported, the challenge is some people don't report, right? So I'm not from the United States, so I might not report that. I may tell you where I was born, but I may not. Because the questions ask you, where is your country of origin? how long have you been in the United States? And some people are a little nervous about answering that. But even when you look at non-Hispanic Black data, it's not broken up into foreign born and US born to get a percentage. And I've asked those questions personally because I find that if you were born in another country and you spent 30 some years there, your social or socioeconomic status, your healthcare access, all of those things play a part into your reproductive health. So, but it is a challenging space.
Thank you for that. I think we had another hand, Sharon.
Thank you, Dr. Newman.
Hi, can you hear me?
Yes.
Okay. I'm sorry, my camera for some reason isn't working, but I'm glad to hear that my voice is working. I had sort of a related question, and it is about whether we had data on whether people had received prenatal care and when, because I think that more significant than where mom was born might be whether she accessed prenatal care. So, that would be something interesting to know. So that's one question. And then the second question I had was related to teen pregnancy and the seriously significant high rate of Hispanic teen pregnancies, and whether there has been any effort to do an in-depth analysis. Are these high schoolers? Are these kids who stay in school? What are some of the contributing factors to this? Are these children who are being manipulated or abused or in some way? And is there a way to maybe think about that a little bit more? I mean, I think the teen birth rate in Prince George's County is similar to that in the state, but it's too high for everybody. But the one for the Hispanic young girls, it's ridiculously high.
So Deborah, okay, do you want
Yeah.
to comment?
Sure. So for your second question about the teen birth rates, again, like I mentioned, this data is from the community health assessment. So like Dr. Newman had mentioned, it's it's survey data. So that data is a lot different than something you would get from like vital statistics or death certificates or birth certificates. So the idea of trying to understand some of the why for some of the data that we have in the community health assessment, and this is a big one, is to try to understand that better. We are trying to explore doing more qualitative analysis on some of the data that we got from the community health assessment, and then collaborating with some other groups to figure out some other departments to figure out, how to better answer that question of kind of why we're seeing such a huge discrepancy in some of these issues when it comes to in relation to some of these disparities. So we are trying to do more qualitative analysis to understand more of the why. We just haven't got to that point yet.
And I thank you. And I see Kim.
Yes, I know I wanted to add, and this isn't a direct association, but we also do see a lower graduation rate in our Hispanic high school students. So we don't know that that's related to teen pregnancy, but it is something that's there. I don't know if anybody's done a look into what rate of young parents do graduate. But that's a very interesting point.
Any other questions for Deborah?
All right, hearing no additional questions, I want to introduce, and we've already had a chance to welcome her into the conversation, Dr. Kristen Newman, our program manager from Family Health Services. So thank you so much, Kristen. Floor is yours, Dr. Newman.
Thank you. So good afternoon, everybody. I was asked to kind of talk about programming for moms and babies. And what I will kind of share initially is that Healthy Beginnings is an overarching program name that covers a lot of things. We do prenatal and postpartum case management. It also is driven through program planning from the data that we get from fetal and infant mortality, and then specifically from child death review as it relates to infant deaths for children under a year of age. So our overall goal is to improve maternal and infant outcomes in Prince George's County. Next slide. So who we serve women of childbearing age, pregnant, postpartum, and we can work with infants up to 2 years of age. And it's primarily through education and case management, working with moms, the families, connecting them to resources. We do not have an income requirement. We do not have a first-time mom requirement. If you are a resident of Prince George's County and you have a need, we will work with you. So um, it is voluntary, so no one is forced to participate in the program, but there's different levels of working with the moms and their babies, and it really is driven by what mom needs. Next slide. So I thought I would kind of give you a sample of these are the people that we serve. So although we primarily serve moms during the prenatal period, and it's anyone of childbearing age. So we've had children as young as 12 in our program, and we've had women as old as 50. We have teens who are pregnant, first-time moms, second-time moms, moms who are having a pregnancy after a loss or multiple losses. We provide some group education opportunities for them. After the babies are born, we work with moms, of course, of all ages, nationalities. And then in some instances, we work with dad, right? Because sometimes dad becomes the primary caregiver. In the last 12 months, we've had 2 fathers who were enrolled in the program because the moms unfortunately passed away immediately or shortly after childbirth. Next slide. So all of our services are provided by nurses. We do have an administrative assistant who is bilingual, who assists and does some of our initial intake questioning. But all of our services are nurse generated. So, and it's done through telephonic case management. That can include text messaging, phone calls, and even emails. We use WhatsApp, we use FaceTime, we use pretty much whatever's available. And we also make home visits. Next slide. So our prenatal case management. You can enter into prenatal case management with us at any time during your pregnancy. If you are a part of our prenatal program, once you're enrolled, we will follow you up until 6 months postpartum. Next slide. So we have offering education and assessment. So when you first come into the program, we do a complete assessment to see what your educational needs are, what your experience with pregnancy and motherhood are, what education do you need, and what resources will you need. So we do things like prenatal nutrition, about drinking water, managing your stress, initiating prenatal care. So with our non-US residents, a lot of times we're assisting them in trying to obtain care. Now, the good news is on July 1st, I have been told it's going to actually happen, the Healthy Babies Equity Act will go into effect, which is going to really change the trajectory of things for our residents here in Prince George's County, because if you would otherwise qualify for Medicaid, you will then qualify if you're pregnant, regardless of immigration status, for health insurance, and you'll qualify to get Medicaid, and you'll be able to keep your Medicaid for 4 months postpartum. So it's not the full 12 months postpartum that someone who is a citizen would have the opportunity for, but it is 4 months postpartum, which is outstanding. So that means they'll be able to get established with birth control postpartum. They'll be able to get their postpartum visit, and hopefully we'd be able to address any concerns with postpartum depression, postpartum hypertension, diabetes management, and so forth. So that is really positive news here in Prince George's County, because it will be absolutely beneficial to a lot of the clients that we actually serve in our program, as well as other women. We provide care coordination for them, assist them with problem solving, identifying their needed resources, and we refer them to many community programs. Next slide. We also provide community connections. So one is prenatal care, the other is medical insurance. So some people, when they come to our program, haven't even signed up for their medical insurance, whether it's straight Medicaid or it's emergency medical assistance. So currently we're assisting women who are not eligible for insurance to apply for emergency medical assistance, which is providing insurance to assist with the delivery. It does not cover prenatal care. We can connect them with community health workers. We provide some prenatal classes. We connect them to job training, work with the school system to try and get them connected with the high school homeschooling for after they have their babies, transportation needs if they qualify, if they need home goods, SNAP, TCA, they need a cell phone, homeless shelter information, anything that you can think of that a pregnant mom would need to be successful, our nurses will work with them and connect them. Next slide. So postpartum case management. So now we have a baby, and that's really, an exciting point. I can say that the majority of our women who are in our prenatal program actually are delivering at late preterm or later, which means that most of them make it to 37 weeks. We've had a few cases where there were medical situations that could not be avoided and they had premature births. But for the most part, we've had most of our babies delivered after 37 weeks. Next slide. So again, once mom has the baby, we provide education and assessment. It is all nurse directed. We teach them about infant care. We provide maternal mental health screenings, and that's not just one time. So we know that mom can have problems with postpartum depression up until a year after delivery. So we screen them on our initial contact, and then based on that screening results, we'll determine the frequency that we continue to screen. We educate them on maternal warning signs, which are some of the factors that can lead to maternal mortality. So we teach them about what to look for, when to get help, when to go to the emergency room. We assist them with postpartum follow-up, so reminding them to go and get their postpartum checkups, educating them about birth spacing and birth control. We discuss infant nutrition, encourage breastfeeding. If they're not breastfeeding, we make sure that they're feeding properly, because there is a mindset that every time our baby cries, we should feed them, and that's not necessarily the healthy way. We work with mom on her nutrition, and we educate on safety and infection control. And that's just to kind of give you the tip of the iceberg here. Next slide. Other community resource connections, of course, are WIC, making sure that the baby is connected to care, the child care scholarship. So that's a great benefit to parents who need to go back to work. And it doesn't matter if mom or dad have immigration status or not, the baby qualifies. So the baby can be qualified to get the scholarship to allow them to go to a safe childcare provider, and the parents can then continue to work to support the family. We work with them about medical insurance and making sure that they get the medical insurance for the baby. If they have challenges, we work with Health Connect and make sure that the paperwork is filed properly and that the babies are going to the physician on the pediatric schedule. We can provide additional support for breastfeeding or refer them out. We work with getting them connected to mental health providers. That should say food pantries, diapers, clothing, home goods, TCA, SNAP, and the homeless shelter as well. Unfortunately, housing is a really challenging issue, even with prenatal and postpartum women here in the county, there's very little assistance when women have nowhere to go. Next slide. So safe sleep. One of the things that we make sure that every family is educated on is safe infant sleep. This is something that is preventable, and we have had a consistent number of sleep-related deaths for infants under a year of age in the county, probably for the last 8 years while I've been in the position I'm in. So we educate all moms, dads, caregivers about safe sleep to hopefully prevent preventable death. Next slide. And so we have some safe sleep projects. We provide pack and play cribs if a mom doesn't have a place that's safe for the baby to sleep. We do individualized education. We do resident education sessions with the community. And we also educate community stakeholders about safe sleep so that when they go out and interact with families, that they're able to provide that same education, because we don't always all connect with the same residents. So we want to make sure that everyone is providing that message, we're speaking the same language, and that we really are keeping our babies safe. Next slide. I think that's it. Any questions?
I just had a question. You probably mentioned before, but generally, how do mothers to be hear about the program? How do they find out about the program?
So we have a lot of community partners who refer to us, and that's primarily, we do have a page on the Prince George's County website that has a flyer on it that people can access and call the number. We get referrals from DSS, we get them from the hospitals, we get them from OBGYN providers, and we get a significant amount of self-referrals. We also get referrals from the ACCU here in Prince George's County for women who are considered high risk. So for example, if they have a previous loss, they have a mental health history, a substance use history, if they've been diagnosed with diabetes or high blood pressure, any number of medical issues and risk factors.
Great, great. Thank you.
Looks like there are several hands that have been raised. I think I saw Anya raise first, and then Cynthia, then Sharon, then Deborah.
Thank you so much, Dr. Newman. This was very interesting information. I was wondering if you could speak a little bit about the data in terms of unduplicated count of people that you are able to serve. I don't know if it's like on average monthly basis or cumulative annual basis, but some sense for the number of folks that you're able to serve. And another question is, your ability to provide services versus the needs of the community. If you can also address that, to what extent there are sufficient resources in Prince George's County and specifically within Prince George's County Health Department to address the needs of our community. Thank you so much.
Okay, so we do not currently turn people away, but we do have to triage their level of need. Everybody is given the connection to services and resources, regardless if we case manage them on an ongoing basis. I have 4 nurses that work with me, and so roughly they carry anywhere from 50 to 75 clients a month, and sometimes it's been upward of 100, which is not necessarily manageable. However, we have a lot of needs here in Prince George's County. And so if even myself with my multiple programs and hats I wear, I sometimes take on clients as well just to get us through a tough time. But I'm also the liaison and the person who the nurses come to get advice when we have complicated cases. So I'm very involved in most of our caseload on a consistent basis. As far as the Prince George's County Health Department, We don't provide prenatal care here. So everything is in the community and it's very hard to come by. So I will be honest, resources are difficult in our county. We used to have uh, more access to prenatal care, especially for people who were uninsured. And that has actually dwindled over the years. And in some cases, it can be upwards of 2 or 3 months to get into care because the need is so great. Now, that being said, after July 1st, we'll see that shift. So I am so, you know, excited about that because it's going to be very significant here in Prince George's County because we won't have to refer people to places where it may be the second trimester or later before they get into care. But if you don't have the ability to pay, there really isn't anywhere to go other than some limited places. And even then, it's not always free. So as far as other resources, so in the Prince George's County Health Department, if someone needed immunizations, we would refer them to our immunization clinic. If they need WIC, we have the WIC services here. So, and because we have a relationship, we're able to assist and facilitate our clients in getting those services. So say mom doesn't have a ride to get here, she can send us her documents via phone. We'll print them out and take them downstairs and help facilitate getting her into the WIC program. As far as if they need birth control, we refer them here to the Reproductive Health Resource Center. If they need pregnancy testing or STI testing, we'll send them here as well. But for things like housing, the health department doesn't provide those kind of resources.
Thank you. Who was next?
Dr. Bauer, go ahead.
Great, thank you. So this is, and again, I guess I'm like Sharon. I don't know why my camera is not working, but I'm here. So yeah, this was a really impressive range of resources. But I heard what you said about not having the primary care providers at hand. So being from the Center for Health Literacy, what I was keying in on was a lot of the information and education that the program also provides. And what I'm wondering is, given that, as we all know, birth is just the beginning of a very long journey with this child. Has the program ever tried to approach this in terms of thinking about the health literacy skills that the mom and or the other caregivers are developing as a result of the program and how that might carry forward in terms of how they interact with their child and child development? Has that ever been something that's kind of been on the table for discussion?
So you're asking if we look at the health literacy of the client?
No, well, that might be part of it, but what I'm wondering is the information and education, which seems pretty extensive throughout the program and coming from a lot of different areas. If you've looked at what difference that information and education makes for the mom's health literacy skills going forward, so in terms of what happens after the birth, because it sounds like this is, no matter when they enter your program, they're going to be getting some pretty intensive information and education about different topics. And I'm wondering not just how does it change what they do in the moment, but does it kind of change them and kind of build health literacy skills going forward even after they give birth?
So I would say that's probably on a case-by-case basis, depending on the individual. But information is provided to people at their literacy level. So if you can't read, we send you pictures. If you can't write, we find other mechanisms to go over information with you. The idea is that when you are no longer with the program, that you will have the skills to navigate things the next time if you have another baby. So I would say it should build that health literacy that translates. However, we also have, I would say, part of the population, they they want us to do all of the work. And so sometimes that's a challenge because if I do all of the work for you, the next time you have a baby, you're in no better a space than when we got here. So usually, for example, if I need you to uh, check on your baby's health insurance, your application, we'll give you the information to reach out and or assist. Maybe my assistant might help with a translation if there's no translator where they're calling, right? So we'll do a three-way call. But mom needs to take the initiative. Now, if she tries and then is not successful, that's where we would step in, because the idea is the next time you should be able to go and do it for yourself.
Okay,
Does
great.
that make sense?
Oh, yeah, totally. And I was just wondering, are you asked to kind of track any of that, or is that something just more that you know from your program experience?
So I would say it's more than I probably know it from program experience. I
Okay,
don't have the capacity to track any more than we track currently.
okay, okay,
I probably have a 15, 20-page report I have to put out quarterly of
okay,
just data points. And
okay.
yeah.
All right, great.
Wow.
Thank you.
Mhm.
And so I think we'll take this one last question. Sharon, I think Sharon, and then I don't know if Deborah still had a question, but Sharon, and then we'll wrap up. This has been a great discussion.
So thank you, Phyllis. I do want to follow up with some things because, the capacity is a concern. So, Dr. Newman, what I would ask you is if there were no resource limitations, or what would it take to build capacity to see all the people who come to you, in terms of dollars and staffing? Because also carrying 100 people on a caseload is a it's not a good experience for either the provider or the or the recipient. What would
Well,
it take?
I would say that it's the provider who, in this case, that's really probably the as moms get further out, it's not as intensive. But yes, 100 is not reasonable, and that's why I've really made the effort to um, manage things differently in the last probably 6 to 12 months. What would it take? This is
Yes.
my wish list.
Yes.
I think I could see having at least 6 nurses on the prenatal and postpartum side minimum. Um, Also with some community health workers and a couple of licensed clinical social workers. So that would really be the ideal team.
And my next question is, are you prepared for when the Healthy Baby Equity Act goes into effect in July to be able to start enrolling non-English speaking women into Medicaid?
So that actually is a question for MCHIP. Because they do not work underneath of me. However, we have already identified all of our currently enrolled clients who will be able to transition over into Medicaid with the Healthy Babies Equity Act. And I would say we will start July 1st with our clients. Of course, I think that's a Saturday, so probably be the following week, but we will start immediately contacting them and giving them the link and getting them to go through and working with them to do so. I was in a presentation on Tuesday, and my understanding is the state is set up to actually assist and contact those women once it goes into effect. So I think we're on a good trajectory. I can't speak to the whole county. But yes, as a matter of fact, after that meeting, I went through and identified all of our ladies who were going to rush to get on Medicaid.
Yeah, I mean, I suspect it's at the county level, you're going to know who those eligibles are. The state's not really going to have a way to know that.
So I'm talking about MCHIP at the county level. I am not a part of MCHIP. We are a separate program. So We're going to work with the Healthy Beginnings clients to help them facilitate that process. But as far as the entire county, that's something out of my purview.
I understand. Thank you.
You're welcome. And Deborah, I'm sorry.
Go on, Dr. Newman.
I was going to say, and Deborah, I'd like to connect with you offline.
Definitely, I was going to say the same.
Okay.
Well, let's give a big round of applause for both Dr. Newman and Deborah Collier. We really appreciate your presentations. Thank you. Woo-hoo-hoo. Okay. Thank you. That was really great discussion and good questions. All right. So, you know, as we're moving into our new season, it's been a while since we have fully reviewed our goals and objectives. And so as we now have the community health assessment and we're kind of getting our footing back from the our time working through the pandemic, we're beginning now to look again at our strategic planning and our goals development. And so I just wanted to, we are going to just share some of the accomplishments over the, you know, through this pandemic period and into now. And we just want to do some introductory discussion today about our you know, the past goals and our accomplishments related to that, some of our ongoing efforts and goals that we may want to explore. So I'll do an overview, and then Zirk Sazer is going to engage you in a discussion on just brainstorming some ideas and for goals and strategies. And then in our June meeting, we're interested in having a full discussion about goals and to narrow down our what our goals and activities will be moving forward. So a number of you on, it's great to see some folks that we haven't seen in a while come, because this is a lot bring insight into the work that was done in the past. And so we had a major programmatic focus starting in 2018, which culminated in a summary report. I believe it was 2020 and into 2021. Dr. Stacy Little was the chair of the HIAP committee, the Health and All Policies committee, subcommittee for the Health Equity Workgroup. And so she, along with members of the HIAP subcommittee and the entire work group, worked on a number of initiatives that are reflected in this report. And primarily this document under sort of one umbrella provides an introduction to HIAP and health equity related definitions. And so it provides definitions and overviews so that when we're talking about health and all policies, when we're talking about health equity, we have a shared understanding. And so the summary report really captures the work that was done in the Health Equity Work Group and the related HIAP efforts to increase community awareness and engagement. And that report, we'll check to see if it is on the Health Action Coalition site. If not, we'll post it because we would love for you to take a look at that report as we go into our discussion in June. And some of the major highlights in the report, past the definitions and overviews, is there were a few case studies that were conducted, asking groups to look at ways in which health equity and health in all policies touch their organizations or and the work that they were doing related to health equity. So I believe in the report there are 3 organizations that responded to the questions from the case studies. The report also highlights the 2 forums that took place in 2018. And the theme of the report and the theme of the forums was transformative change. Again, our role in achieving health equity for Prince George's County. And so part 1 really engaged elected officials, agency leadership, health providing organizations, and some of our academic partners. And if I recall correctly, we had well over 100 people attend that first gathering. And then the second forum took place later in the year, and it engaged other stakeholders and nonprofit organization leaders and community members. And together, there were recommendations that were made, which I think, again, may inform some of our thinking as we look at our going through our process and looking at our goals. And then we had participation in the RAND report from the Health Equity Work Group in looking at assessing health and human services needs in the county as we look at health and all policies. And then some of you were very engaged and instrumental in our work in the County Resolution 127, which was adopted in November of 2020. And that basically said that the county will certainly take into consideration and recognize the importance of health in all policies. It wasn't particularly a deep dive, but it was a beginning that the Health Equity Work Group had, a hand in moving forward. And then there are issue briefs, which you can find on the Health Action Coalition site under the Health Equity Work Group. And so there were issue briefs on COVID-19 and the Prince George's County immigrant community, and also an issue brief on the impact of structural racism on Black Americans through employment and economic policies during COVID-19, the COVID-19 pandemic in Prince George's County. So you can see that we have done a lot of work and we continue to do a lot of work. And as you know, there was certainly engagement of the county council. Sherry Curtis, our past co-chair, did an excellent presentation before the county council. And in that engagement, we were designated a county council liaison, who is Dr. Hancock. You'll notice that Dr. Hancock hasn't been able to join us. She is waiting for renewal of that designation and will join us when she can informally. But she's also waiting for, again, confirmation and renewal as we're in a new council of that designation. Any comments or questions before we go to the ongoing efforts? And again, I just want to acknowledge the work that the entire health equity work group did in making all of these efforts happen. And so they represent uh, uh, 2018 to 2022. And what we've been engaged in as an ongoing effort that grew out of some of these recommendations in this work is the Health Equity Champions Program. And we're, again, happy that we continue to collaborate with our partners at the University of Maryland and the therapists, the students at the Terrapin think tank. So we are looking to finalize and explore ways of implementing the curriculum, and hope to have some announcements related to that fairly soon. And then as we, Kim, can you, I don't know if you can scroll up the slide or not. For some reason, my screen is blocking what's here. And then as we look at some of our strategies and goals, let's see if there's a way. We're looking at promoting, expanding, and supporting implementation of HIAP legislation. So we're always interested in the HIAP legislation, and we try to find words to express that, and then we want to develop health communications framework for mass events, and that's would be something that these are things that we want to explore as we move forward with some of our new goals and activities. Any questions, comments, reflections from anyone related to things we've done in the past? Sharon?
Yeah, there's some follow-up we could do related to that health and all policies resolution. Before he left, Dr. Askew presented a plan, an implementation plan, which it was now feels like so long ago. I would have to go back and re-look at it to see what it actually said again and refresh myself. But I think one of the things, and I'm not really sure what role this group would have, but there were very specific deliverables in that legislation. For example, requiring all grantees to submit a health equity plan and report on their health equity work, and some other kinds of very specific things. I don't know if those were ever implemented or whether there's been any movement, on Dr. Askew's plan. I think that given the fact that the health department is seriously understaffed and there's been a lot of leadership transition, I see Anya just put in the chat that CR 127-2020 was never implemented. I don't know what our role is in terms of holding people accountable for passing a resolution and then not doing anything with it.
Right.
But we should think about that and come up with a strategy, if nothing more than to submit a request asking for information, or kind of what their plan is, or or whether they're just not going to implement it. And it's so many different people now, so many different players are at the table. It's hard to know what to do.
I can't say what the current status is, but I know I worked on the PowerPoint with Ania and Dr. Askew. Unfortunately, I don't have the PowerPoint anymore since I've since left the county and returned, but I believe Ania should still have it, so we could review that, see what existing plans we made. Because I believe different items were designated as council responsibility, others would be health department, others county executive. Um, but again, theoretical.
Were those things in Dr. Askew's report, as Sharon is mentioning, Amber? I mean, in his recommendations.
I believe so.
Mm-hmm.
I think he did. I think he went point by point. And you know, I may have a copy of it. I keep everything. I'm a pack rat. Um, so I'll check in my files, and if I have a copy, Kimberly, I will send it to you and you can send it out to folks.
And this is one of the reasons that we included strategies and goals to explore, and that kind of falls under that promote, expand, and support implementation of this HIAP legislation and support implementation. And the reason I use the word support, it is because we as a volunteer organization, unless it is something in our particular thing that we do for work, we, we would, we would have to be clear on what our, determining what our role, what our suggestions are related to implementation. Someone else had your hand up, Dr. Bauer.
Hey, yeah, it's Cynthia. I know that a lot of the things on the accomplishments here are like, reports and policies and things. I do think the group should take credit, though, for the really tremendous um, spontaneous group that came together and really sustained those early days of COVID vaccination. That was an amazing group, and it continued for a year or longer. Kim shaking her head, yes. I mean, because that really became the water cooler place. Like, if you wanted to know what was going on with COVID vaccines in the area, not just the county, but like over into the district and around the area, that was the place to go for quite a long time. And I think that's quite a tremendous accomplishment to have that group to come together to do that kind of networking and information sharing and really make sure that, I mean, there were people like, oh yeah, we're doing this, you could be there, blah, blah, blah. So I think that was like a really great example of how a coalition can fill gaps that would have gone unfilled. Because I mean, I know I was on some of those calls where people were identifying groups that had been overlooked and people were jumping in. I consider that a really tremendous accomplishment. I don't know how we would put that in a bullet, but I would encourage us to think about representing that. And I know that the Health Literacy Work Group had done a few other things too, but I really think that one around COVID vaccinations was a tremendous accomplishment.
Yeah, and thank you so much for pointing that out. And this is one of the things that is so important is as we are moving forward with this, please send any of these kind of things to us, to Kim, and copy the Zerksazer and I, because you're absolutely right, Cynthia, in that a lot of the people who were engaged in some of that initial work came out of, I think it was the Health Literacy Committee and the subcommittee of the Health Equity Work Group. And a number of the people who regularly attended the Health Equity Work Group made up, an important body of people who participated in those discussions. So thank you for raising that. And I do encourage all of you, if there are other major accomplishments that we did not include, send those to us so that we can make sure we highlight those accomplishments. I think embedded in this summary report of the transformative change highlights a number of important initiatives that also took place that are in that and that are reflected in that report. Kim, oh, I'm looking at the time too.
Thank you. I'll keep it quick. I just thank you, Dr. Bauer, for bringing that up. The ad hoc vaccine working group was critical. I think we saw major shifts in recognizing our Hispanic populations in the county for vaccination. So that was such a great work group. And I think it could really fit into this first bullet under strategies and goals to explore is just lessons learned and how to develop a health communications framework, because we know we can send messages out and ask people to repeat them, but it was really the group where you can hear the live feedback of what's happening on the ground, where we can have those discussions and communicate. So I think, identifying and quickly being able to pull together an impromptu group should absolutely be a piece of that plan.
Yeah.
And I have a draft of, I don't remember but if you remember, Leah Barnes was my student and she was working for a while. And we have been trying to gather information from people and kind of pull together lessons learned. So I have a draft that I can send to you. It's still pretty rough, but I will dig it out of the archives.
Excellent, excellent. Well, thank you all for that discussion. And Zerxaser will do the goals activity. Thank you all. That was good feedback. I wonder did she drop off?
She may have.
I fell off, but I'm back on again.
Okay.
While we're here, I'm gonna go ahead and add the points that everyone has added so far to future goals.
This is Cynthia again. I don't know how much information is kind of getting out, but the state does have this mandated Commission on Health Equity. And they are busy working on a health equity, like reporting structure and dashboard and all those kinds of things. That might be something to kind of think about what role to have with that work.
Mm-hmm. Great. I hope nothing is happening. I see several have dropped off. So hopefully Zerxaser will be able to get back on. In the meantime, we just want to open the discussion to talking about, as we move forward, we want to just do a general brainstorm. So some of the things that you've mentioned already, as Kim is including, can just be things that we need to consider as we're moving forward in updating our goals. So I'm just going to open the floor, and if you want to raise hands, I will call on you. But whatever your thoughts are regarding goals or strategies or things we need to consider as we move forward. Any ideas? I see Christine. Christine, I don't know if you have some thoughts on forthcoming goals. Anyone have other ideas or thoughts as so hopefully some of what we have, what we shared in this previous slide might be helpful. I think certainly, Kim, we want to put something about continuing the health equity champions program and moving that forward. And I put something like maybe in parentheses, put partner, solidify the partners, uh, because there are groups that are interested in uh, uh, implementing. Cynthia, did you have your hand raised?
I didn't, but Kim, you had said that you thought there might be something from the ad hoc group to carry forward.
Yes, I'll go ahead and add kind of more on that. Just emergency communications planning outside of government agencies.
Right. Well, and just as an FYI, UMD is actually funding me and about a dozen other faculty to work on pandemic readiness as it relates to social and behavioral issues. So we would be happy to have further conversations with this group about sort of, applied research that might be useful as, you think about the whatever pandemics are coming next.
Yeah, and thank you, Cynthia. I was going to actually double down on that. Well, asked to have emergency health communications planning expanded to more emergency preparedness in general. So not just communications, but how are all of our county assets prepared and positioned to respond.
So Kim, you may know this. I guess there's a switch to starting to talk about this as readiness as opposed to, is that kind of the new word that's replacing preparedness in some circles or not?
Possibly. I think readiness definitely comes up a lot. Preparedness is still
Okay.
in the language. I mean, I think we could definitely support and coordinate with the Office of Emergency Management, to make sure that their plan, they have resources. It's just making sure that we connect people with the resources to get the updates, to get the communications out, and how we can, and maybe just getting ideas from our external partners of how to use those resources better.
Yeah. I mean, it is a risk communication challenge because everybody wants to say like, okay, the pandemic's done. I don't want to think about that anymore. Let's go back to what we were doing or whatever the new normal is. But I mean, that is what preparedness is about, is trying to get people's attention and doing things even in the absence of an immediate threat, right? So I think that's also from a public communication, public engagement perspective, how to engage with different parts of the county on this readiness preparedness idea.
And I just noticed Zerxazer is back, so I will step away and Zerxazer.
I am back. I am so sorry, and I apologize if it's a lot louder than where I was inside. My computer battery had died on me, so I needed some charge. But I'm not exactly sure what I missed, but I did want to echo one of the goals or strategies that was mentioned last meeting. I believe it was from Dr. Bauer, and it was a proposal to the Board of Health on, I believe it was pipeline programming we had talked about, and engaging our health professional schools, our nursing schools, for example. As we're training our future health professionals, it's important to also have them engaged in this work, and touching bases with those schools as stakeholders, and being more present and involved in some of these efforts. Um, One other goal I believe that was mentioned was um, oh yeah, the impact on the capital region. And as we were taking a look at the community health assessment, what impact that the capital region to Prince George's County has had in meeting some of those needs. So I believe those were both ideas. I'll credit those to Dr. Bauer, but wanted to make sure that they were highlighted in this meeting as well.
Can you elaborate on the last goal that you brought up, the capital region?
Yeah, I believe it was from the overview that Jake had provided regarding the community health assessment. And I think we were just kind of, it was a question, I think, and Dr. Bauer, please correct me, but we were just, wanting to find out what impact in meeting the needs that that the community health assessment had brought up. What what has that done for our community? Is it has access increased? Have resources increased? Um, of that nature. So, and Dr. Bauer,
Yeah.
you're free to elaborate at all.
Yeah, I mean, I just like because I guess my arrival in the county corresponded with the right before the groundbreaking for Capital Region Medical Center. There was just such high expectations, and there was a lot of enthusiasm about what a difference this new hospital with all these new facilities and capacity and everything that we're going to bring. And I just asked Jake, I said, are you seeing that in the data yet? Right? Are we seeing any improvement in any of these key areas like heart disease or cancer or any of these other areas? And he said he was not aware of that. And I said, well, seems like we should be asking Capital Region those questions, right? What have you done for us, right? So, yeah.
Yeah, those are important. And I want just another thought is just to look at the community health assessment in terms of their key findings as we again plan out what our goals are going to be. So taking that into consideration. So this isn't a particular goal statement, but just as we do what we're doing to look at that, the findings in that report and other reports.
Well, I think especially in light of the presentations today about, just limited healthcare access and services not being sufficient for the need, right? That kind of also, I think, part of just the broader context of making sure that the elected and appointed officials and healthcare leaders really understand what the on the ground needs are.
Mm-hmm. Yes, yeah. And just in general, considering these documents, and because I know that as we discussed after the presentation, there are some concerns with the number of respondents, right? However, there are still things that are probably not surprising to any of us in terms of the findings. Anything else, Sir Caesar, related to the us brainstorming the goals?
I think these are really great ideas and goals to start off with. As we're moving forward, as we can see in the last slide, there was a lot of movement, even in the midst of COVID, and social justice reform within this coalition. So it was great to see some of the accomplishments and work that this coalition's been working through. And yeah, I mean the list is really great, really robust. So I'm glad to see what we can do in next steps for it.
I want to also acknowledge Anya. I just saw your hand, and then Christine's hand raised.
Thank you so much. I appreciate it. Just wanted a little correction on the first item. As far as I can recall, Dr. Askew did not really present an implementation plan. He promised, he promised to present an implementation plan. And that's why we were all upset when he then resigned and left, because actually we never received the plan. And then other two issues is the 2022 assessment is a very, very valuable document, especially, looking at disparities in health outcomes. However, I think that one of the critical pieces that is missing in understanding the full scope of disparities is with regards to the resources and the capacity of Prince George's County to actually deliver the services, so we really don't know. I mean, did the number of doctors who provide certain types of care increase over the years, or did it increase? So we're looking at the outcomes, but when it comes to the field of, especially public health, because that's what our officials, right, can influence a little bit more than some other things, there are no direct connections. And then my second point is also with regards to resources and capacity. Essentially, the coalition is one of the key means of potentially holding our decision makers accountable. So, so the question is, hey, what exactly did you do, to improve health equity in Prince George's County? Is a question that should be asked, in my opinion, from our community, of our politicians on regular basis. Because if you look at what's going on with health department, with their budget, with the number of vacancies that they're carrying, it is unfortunately a very, very sad picture, and it is not improving. And they are taking steps to support recruitment efforts, for other agencies. And I know that Dr. Sami is really, working hard on some innovative strategies, for example, of converting more limited term grant funded positions into merit grant funded positions. So at least those folks will start getting some benefits, but it's really uphill battle. And I get to see, how the difference in allocation of resources between different agencies. So as a lot of you already know, health and human services agencies not high on that totem pole. So I think that asking, and monitoring exactly, you guys can serve, like, you can be that mirror, right? that asks, what exactly have you done to foster all this great, goals and objectives that you yourself proclaim to support.
Right. And so I want to be mindful of time. Thank you, Anya. And Anya, I want you to think of that in terms of how we shape some of those thoughts if we decide to take that on, to look at that, how we shape that into goals, which we're going to really hone in on in our June meeting. Christine, and then we'll come to close.
Yeah, and actually my comments kind of relate to what Anya just mentioned. One of the bullets on here is proposal to how to engage health professional schools, nursing schools, etc. I do want to highlight the fact that we are not just talking about clinical staff. So I think Anya's point just kind of it relates to what I was about to say, that we do need public health and people who have understanding of public health. I think there is a drain. People are drained. We're tired. We're tired. I think there is energy. Like hear a lot of young people. So I'd like to double down and just clarify that, because I think often people see health professionals and just think clinicians. So I just want to make sure that it's clear that we're talking about public health, people in public health who can support other roles, and not lose that, because that is important. Because we're not going to.
Yeah, and I would also go as far as to include health administration too, because that's
absolutely.
Yeah,
and
important as well.
And a lot of that, and that's why I think it would be good to read some of the reports, because they have a lot of that kind of language that you're talking about. And I do want to just emphasize that this is kind of a teaser activity, just to get us to start throwing things out. So a lot of this is going to be, reshaped, not included, changed, all of those things. So this kind of just gets us to start getting our thoughts together on ideas as we go into more specific kind of work in in June and really shaping it in June and in between that time. So I want to thank everyone for attending. It is 5:02 and we had great discussions. The next meeting is June 15th at 3:30. Please encourage anyone who's interested in really helping us move forward and shaping those goals to participate, to join us in this meeting. And I wish I had time for more announcements, but I want to also respect your time and appreciate that everyone was able to join us today. So thank you all, and thank you for your input and engagement today. Okay. Anything else, Kim or Zazer, as we're closing?
For me, I just put the link to RSVP for the full coalition quarterly meeting on June 13th. You should have, if you're on the listserv, you should have also received a notice, but I put that in the chat as well, and it'll be with the notes. Thanks.
Thank you all. Zazer, you good?
Yes, thank you all for joining today.
All right. Have a great one, everyone. Take care.
Thank
Thank you.